is going to involve those structures. And thus the management strategies are going to really revolve around that. These are the most common skull-based tumors that we see in practice, and really this is by histopathology, so it's obviously biased for those tumors that go to surgery of some sort. Meningiomas are by and large the most common tumor. If you clump these three diagnoses, really four diagnoses: nerve sheath tumors that incorporate schwannomas, neurofibromas that occur at the base of the skull, pituitary tumors, craniopharyngiomas. Those are really tumors that occur at the region of the sella turcica, and meningiomas. You really account for almost 50% of all tumors in the brain. So the pathology that we'll talk about really revolves around these very common diagnoses. So pituitary tumors, we usually classify those into tumors that secrete too much of a hormone, or non-secreting tumors that influence the secretion of the normal hormonal axes. Meningiomas, and we'll briefly touch upon benign and more aggressive entities under the umbrella of meningiomas, and then others if we have time. Schwannomas, the most common being vestibular schwannomas or acoustic neuromas, and the management of the less common, but here at the University of Washington, fairly common, trigeminal and lower cranial nerve schwannomas, and finally chordomas and chondrosarcomas. Really the anterior skull base, the first cranial nerves that are influenced by tumors that occur at the base of the skull are really going to be the optic nerves and the cranial nerves that move the eyes. So vision problems, and the most common with regards to pituitary tumors is going to be loss of acuity or visual field deficit. And the reason for that is that growth from a pituitary tumor in the path of least resistance is going to be up, and the optic chiasm sits right above the sella turcica. So we'll concentrate on pituitary tumors for a moment. Again, just to orient everybody to the anatomy, this is a T1 coronal MRI sequence and an optic chiasm here, pituitary stalk, pituitary gland. On either side, the carotid flow voids, and just as a cartoon and schematic, a lot of high-priced real estate anatomy: pituitary gland, pituitary stalk, optic chiasm, hypothalamus, cavernous sinus, which is a large venous confluence that the carotid artery, cavernous carotid artery, passes through, and then in there the cranial nerves. So that's cranial nerves 3, 4, 6, and B1 and B2, the first two divisions of the trigeminal nerve. So you can imagine when a tumor occurs in this location, the path of least resistance is going to be up, but they do breach these confines, either into the sphenoid sinus or into the cavernous sinus. And those different tumors present in much different ways clinically. Things to remember about pituitary tumors: almost always the histology is going to be benign. I probably see a malignant pituitary tumor once a year, and we see right around 3,000 visits in our pituitary center here, so they're fairly uncommon. Endocrine dysfunction, so again, hypersecretory syndrome such as Cushing's disease, acromegaly, amenorrhea, galactorrhea syndrome from prolactinomas, and then hyposecretion. So everybody's seen the commercial with low T, and the man sitting in the corner, sort of in the shade, and that's very, very common, is a patient suffering from hypogonadism. Vision changes, and then apoplexy. Apoplexy is one of these catastrophic, immediate onset clinical entities. Cannot be diagnosed by radiographs, but only by the clinician, and we'll talk a little bit about that. For anybody with a progressive neurologic deficit, that's an emergency. Those patients that come into Harborview with clinical apoplexy usually wind up in the operating room within an hour of coming here. Some of the cases we'll review, just to give you an idea of the types of clinical scenarios we see. 26-year-old patient, female patient with visual complaints and amenorrhea, comes in with this large lesion, and you can see the tumor actually distorts the optic chiasm, and the tumor enters that area of the cavernous sinus and encases the right cavernous carotid artery. Here's another case, 42-year-old female with visual loss in the left eye for 2 years and declining vision in the right eye. I don't know that that's going to show up perfectly, but even on this T2 axial sequence, you can see the left eye that the patient's essentially blind through. The optic nerve is completely atrophic as compared to the contralateral optic nerve, which is nice and fat and robust like one would expect. This highlights it a little bit better, so atrophic optic nerve. And then this is a classic case of apoplexy, 20-year-old female with acute onset, severe, worst headache of her life. It often gets confused with subarachnoid hemorrhage, acute loss of vision, and lightheadedness. Another case, patient with uncontrolled diabetes, 300 to 500 units of insulin per day, and uncontrolled hypertension. Sometimes these patients are on 3, 4, 5 antihypertensive medications and still hypertensive, and poor spatial features. And she's got her splint on for carpal tunnel with this large lesion. And we'll talk about what that is. I would say 90% of the patients we see in the pituitary clinic come in like this. So they have all the things that all of us have: headache, we're fatigued at the end of a busy work day, and our MRI showed this little dot, and our endocrine panel is completely normal. And we'll get to what we do about this and what data from the natural history we can take from the literature to support our treatment strategy. So the frequency of pituitary tumors at autopsy, I always quote this study of approximately 15,000 patients. And these are patients that have died in their 7th, 8th, and 9th decades of life from natural causes. And if you do autopsies through the sella, a lot of them actually have pituitary tumors, about 10% of them. And the vast majority of them are small, so less than a centimeter, microadenomas, macro being anything larger than a centimeter. And since this study, really there are other smaller N studies, 2, 3, 4,000 patients getting MRI scans, and the incidental incidence of finding pituitary or sellar lesions is right around 10 to 15%. So background on the pituitary gland and the sella, we talked about this. Everybody knows the posterior gland transmits ADH, antidiuretic hormone, and oxytocin, and that has a direct neural connection to the hypothalamus. And then you have the hypophyseal vascular axis to the anterior pituitary gland, where all of these hormones are housed. So very intricate system for relaying hormones to the periphery and the end target organs. Again, our anatomy that we reviewed earlier. So again, going back to our MRI scan, I showed everybody the optic chiasm here. One could see this is a patient that came in with visual change. They normally don't say, listen, I have a visual field deficit. I have tunnel vision. I can't see. What they'll commonly come in and say is, I keep getting into these small fender benders, and it's always the left or the right side of the car. I keep hitting the shopping cart at the grocery store, that sort of thing. And one could see that there's a cystic mass here distorting the optic apparatus, more the left optic nerve than the right, and left chiasm than the right. But pituitary gland, again, is going to be affected. Why? Because one can't really see the pituitary stalk, so it's going to influence that. The most common field deficit you're going to see by formal visual fields is going to be this, and that's a bitemporal hemianopsia, so classically tunnel vision. Again, not to belabor the point, but all the signals start in the hypothalamus. They come down the pituitary stalk, just like the stem of the cherry, down to the cherry, which is the pituitary gland, and then hormones get released into the bloodstream via the cavernous sinus, in inferior petrosal sinuses laterally, and those make their way to the target organs. Pathology of the sella, really, it all gets back to the normal tissue and the normal histopathology of the tissue there that gives rise to these things. So we see a lot of zebras in our skull-based clinic, but the vast majority of tumors within the sella are going to be pituitary adenomas, and we'll concentrate there. So focusing there, again, separating them into non-secreting tumors and secreting tumors is a very easy way to come up with a good management strategy. The management strategy really should have these points in mind. You want to maintain or preserve normal pituitary function. You want to get rid of the hypersecretory state, which may lead to a metabolic syndrome. And you want to reverse any neurologic deficit and certainly maintain what's there. So really the options when we see a newly diagnosed pituitary tumor are going to come down to these. One is serial imaging and do nothing. And those are patients who have normal endocrine function. And obviously we take into account the age and the health of the patient. Somebody's on the heart transplant list or 90 years of age and they're doing just fine, almost always we're going to send that patient out with a follow-up appointment and not schedule them for surgery. If you have a 15 or 20-year-old patient, you got to think what's going to be good for that patient for 80 additional years. Medical management, by and large, the treatment of choice for prolactinomas is going to be dopamine agonist therapy in the form of bromocriptine or cabergoline. It does way, way better than I do to cure those disease states and the increased prolactin levels. Surgical intervention we'll get to, but we get very, very creative, and our armamentarium has just become exponentially greater just over the last 5 to 10 years. Radiation therapy, very rarely are we going to use as a first-line therapy, but certainly as an adjuvant therapy to any of these others is very common, especially in our clinic where we get referrals from all over the country and overseas, sometimes patients who have been managed for several decades. Here at the University of Washington, to put a plug for our radiation oncology program, we really have all modalities available to folks across the country. So gamma knife radiosurgery, photon beam treatment, neutron beams, we're the only neutron center in the country, and then our new proton center, one of about 15 across the country. So again, pituitary tumors can be classified based on hormonal secretion or lack thereof, and then on size with the 1 centimeter cutoff. Tumors that are larger than a centimeter frequently cause mass effect. And does size matter? Absolutely when it comes to neurologic deficit from cranial nerves. But again, we take out tumors that you can't even resolve by MRI scan. So patient with Cushing's disease, tumor somewhere there, and we localize it by IPSS. And here's an example of that. And here's a 2 millimeter adenoma. So mass effects, we talked about it. Larger or rapidly growing lesions on one end of the spectrum would be apoplexy, where you actually have a stroke or an infarction of the tumor and sometimes hemorrhage into that tumor. That's a relatively fast expansion of the mass. That almost always presents with headache. And I am really, really good at curing that headache. By taking out the tumor, those patients are uniformly happy at the end of surgery. Visual field deficits, we talked about cranial nerve palsies, again, with that quick expansion. You don't necessarily have to have invasion of the cavernous sinus. You could just have a bowing of the medial wall of the cavernous sinus, and that patient can present with ophthalmoplegia. Diabetes insipidus, as a teaching point, that's a very, very rare, I would say 1 in about 1,000 cases of pituitary adenomas that present with DI. That's more commonly associated with the presentation of a craniopharyngioma. That's a good way to tell the difference between those two entities. So again, coming back to that giant tumor, this is a very nerve-wracking case for the surgeon when you have a very young patient, 42 years old, one eye's blind, and a rapidly declining vision in the other eye. That nerve could potentially be very, very sensitive to any manipulation. So I always lose sleep about these cases. But we can do these sorts of things. So now you can see the optic chiasm, that left optic nerve that was atrophied that we looked at earlier, and the very large fat nerve on the patient's right side. And we can take these out completely with transsphenoidal surgery through the nose. And these patients typically go home within 24 hours. I mentioned that patient earlier with apoplexy. In our center, we don't rest, we don't go to sleep on a patient with declining neurologic exam, whether it's diplopia or loss of acuity. We don't leave that up to chance, because this is a very easy treatment, sort of just like an epidural hematoma. You don't want to go to sleep even though the patient looks well. And again, you can see the tumor's gone. Before, we couldn't see the optic nerves or optic chiasm or the pituitary stalk or gland. On the postoperative MRI, you can now appreciate the optic chiasm, pituitary stalk, pituitary gland, and two gadolinium enhancement signs in either cavernous sinus. I joke sometimes about making the patients feel better. I would say it's probably 10 to every 1 that the endocrinologists make the patients feel better at the number of cases to every 1 that I do. And the reason for that, the vast majority of these patients come in with some form of hypopituitarism. And you'd be amazed how quickly they bounce back and feel better and feel much like themselves, more stamina, more energy with hormone replacement therapy. I'm very, very lucky to work with 3 really good neuroendocrinologists, Dr. Alan Failer, Abe DeSantis, and Brent Dissay, and they're wizards when it comes to replacement and what levels to get to based on the patient's symptoms. So hyperfunction. When growth hormone is the hormone that's being oversecreted, this leads to acromegaly in the child before the epiphyseal growth plates are closed, gigantism, prolactin, hyperprolactinemia, and that's the galactorrhea amenorrhea syndrome. ACTH leads to Cushing's disease. TSH is, again, a zebra. I probably see one of those cases every 3 to 4 years or so. So hypersecretory tumors. This is a very common appearance of an acromegalic patient and a very common picture of a Cushingoid patient with the moon facies, buffalo hump, central obesity. Prolactinomas account for about 40% of all pituitary tumors. So again, going to go straight to the endocrinologist. The patients that go to surgery are the folks that don't want to be on the drug for the rest of their life or have some sort of adverse reaction to the drug. 750 to 900 new cases in the US of acromegaly, and Cushing's disease 5 to 25 per million. I wind up seeing right around 30 to 40 acromegalic. This is new acromegalic patients per year. I would say that part of our program is a lot more robust than in general across the country, and then Cushing's about half that per year. The goal of therapy is of course hormonal cure. I didn't do the patient any good if the growth hormone or the ACTH level is exactly the same before surgery. Why? They're going to still have diabetes and hypertension and lead to decreased life expectancy if we can't do something to eliminate that oversecretory state. So we eliminate the mass effect. So for these tumors causing neurologic deficit, correction of visual fields, prevention of recurrence, preserving the normal pituitary function, and improving hormonal deficits. The gonadal axis is quite rare to see recovery of that, but quite common to see recovery of the adrenal and thyroid axes from decompression of the normal pituitary gland. We happen to be really, really good at all of these things, and that's why we have such a robust center. So the armamentarium. We talked briefly, but there are a lot of additional services that we have here. Neurophysiological monitoring during surgery, pre- and post-operative angiography and embolization. Endoscopic tools, like I say, I think over the last decade have become quite common across the country, and we're one of the busiest endoscopic centers on this coast. We use angled scopes to look into the cavernous sinus around corners. We use 3D scopes to keep our representative orientation correct. We also have, I mentioned, the radiation oncology program, access to all radiation modalities. And nowadays, systemic therapies are becoming a lot more advanced. These are new surgical equipment, microscope versus the endoscope. So the way I usually approach this subject, because I get asked this all the time. I would say about half of my skull-based practice is done with the endoscope, which is not very common. The microscope has a light source outside of the patient. You're essentially looking down a tunnel. Taking the case of a transsphenoidal operation, you're looking down about 10 centimeters down the nose. And there are a lot of shadows and difficult corners to look around. The endoscope is just like a pen going up the nostril, and the light source is at its tip. And like I said, we have 0-degree scopes to look straight ahead. We have 30, 70, and 90-degree scopes to look around these intricate corners to make that safe and to adhere to the number one principle of skull-based surgery, which is essentially don't do anything unless it's under direct vision. And our team here has grown over the last 6 years. We quite commonly chase after tumors in the cavernous sinus that are adenomas. So adenomas are the surgeon's friend. They don't tend to invade the adventitia of the carotid artery or the cranial nerves. They don't share blood supply, which is the case for meningiomas. Adenomas tend to be handled sort of like soup, a thickened soup, and that with safe exposure of the cavernous sinus, those tumors can be removed and lead to biochemical remission in these patients. There's a very famous acromegalic patient, that's Andre the Giant. He died at the age of 42 of a massive heart attack, which is not normal. Everybody here knows that. Second in frequency to prolactinomas. Again, this can lead to gigantism. The growth hormone excess leads to insulin resistance, diabetes, hypertension, all of that stuff. So let me see here. Yeah, we talked about diabetes and hypertension. This is one of the only disease states that the neurosurgeon can get involved with and actually say that we cure diabetes and hypertension. And it all comes back to this. You don't have this precise regulation of growth hormone as it relates to glucose levels in the blood. This is a normal control patient, and the growth hormone levels go up and they nadir very nice and precisely. In the acromegalic patient, this never naders down to normal levels, and this leads to this insulin resistance. So if you give a normal control patient a glucose load, over the next couple hours, you see growth hormone drop. If you give a glucose load to an acromegalic patient, the growth hormone actually goes up. It's dysregulated. And this is, in fact, a test that we use to not only diagnose acromegaly in cases that are borderline, but to say, yes, we've cured this patient or not. So after surgery, if we do our job and the insulin-like growth factor 1 level is normal, the growth hormone level is normal, we need this to actually give them the seal of the biochemical remission. So why do we get excited as surgeons? To me, and this isn't the case in Europe, they tend to biopsy these tumors and treat them lifelong with medical management. Here, I would say 100% of the time, the acromegalic patient is going to be a surgical case. Why is that? Surgery is their best chance, and their best chance for biochemical remission throughout their life. Why is acromegaly such a difficult thing to manage, and why does it lead to decreased life expectancy? And that decrease in life expectancy is 10 to 20 years. Well, 60% of patients die from cerebrovascular, cardiovascular events. We talked about, also it can lead to malignancies, and we have a routine screening protocol for our acromegalic patients who have been cured or not to get colonoscopies every year. And this is what happens. This life expectancy curve is directly related to the growth hormone level in these acromegalic patients. So here's the normal population and normal life expectancy, death from natural causes. And you could see as the state of acromegaly gets worse and worse and worse, their life expectancy gets worse. The good news is if you're here, this is after transsphenoidal surgery, but if you're able to control that over-secretory state with surgery, radiation, or medical management, their life expectancy goes back to normal. So again, the objectives are to control, reverse the symptoms and signs, suppress to normal the growth hormone and IGF-1 levels, control the mass effects and preserve the pituitary function. We talked about the options here. Transsphenoidal surgery remains the most cost-effective and rapid initial treatment. Why? 80 to 90% of the microadenomas causing acromegaly lead to cure in the hands of an experienced surgeon. And in the literature, that cutoff has been labeled 40 cases per year of doing pituitary tumor surgeries. And then macroadenomas, I think this is probably a little bit better since the endoscopic approach has come down the pipe, but probably around 75%. Here's an example of a growth hormone secreting adenoma, giant, and we were able to do this operation with the endoscope. Here's our patient we alluded to earlier. You could see her tumor is a much different animal than this. Here, the tumor has not invaded the cavernous sinus on either side and has essentially followed the path of least resistance with a suprasellar growth. These tumors are relatively much easier, although this tumor is large. It's probably the size of a duck egg or something like that. And the reason for that is here one could appreciate optic chiasm again, pituitary stalk, pituitary glands being smushed over here on the patient's left. Here's the normal enhancement pattern following gadolinium of the cavernous sinus, cavernous carotid artery, and then look at the contralateral side or right side. Cavernous carotid artery, and you could see you lose that nice white gadolinium enhancement pattern, and essentially this tumor has grown into the right cavernous sinus. There's a classification called the NOSP classification. I won't belabor the point, but the bottom line is that it tries to predict cavernous sinus invasion looking at MRI scans. NOSP class 3 and class 4 tumors traditionally in the literature have been thought to be non-operable for biochemical remission. Here's a NOS4 tumor. Again, why is that? Well, in the cavernous sinus, we alluded before, if you open the cavernous sinus, you have the cavernous carotid artery, and then the various cranial nerves. So 3, 4, 6, and V1 and V2. Here's our case again. So 55-year-old female with a history of hypertension and diabetes, found to have a growth hormone level of 29, upper limit of normal is 3, and an IGF-1 level of over 1,300. Upper limit of normal is going to be right around 220, and a NOSP class 4 tumor. Just real briefly, this is an endoscopic approach we did early on. You can see straight ahead, this is the bone. We're taking out the mucosa overlying the bone of the sella. Here's the bone of the sella, the carotid promontory. We're going to start drilling some of the bone overlying the sella. And again, this tumor was eccentric to the right. We're using a kerosene punch to remove that. I'm going to push this along. Here's the dura overlying the pituitary gland, and here on the right is actually in the cavernous sinus, and that white, soft, fleshy material that we're suctioning out and removing is going to be the pituitary adenoma. I'm not sure why, but almost all growth hormone secreting adenomas have no pigment. They're actually bright white. In contrast to tumors that secrete ACTH in the setting of Cushing's disease, which are almost always orange. You could see and appreciate that we're suctioning venous bleeding from the cavernous sinus, indicating that we removed the vast majority of the tumor and decompressed the normal venous outflow. I'm just going to push to the end. Just to give everybody an idea of what we see here. So here's the medial wall of the cavernous sinus. You can see a tiny little breach in the wall, probably where the tumor grew from within the sella. This is the dura overlying the pituitary gland, and this is the cavernous carotid artery. So we're using a 30-degree scope to look into the posterior lateral cavernous sinus, and this is us suctioning and removing additional tumor. This view is impossible to get with the microscope, so we're going to go on. So we always get CT angiograms following surgery to make sure the artery's okay. At 6 weeks, her IGF-1 level was 195, and a no GTT that suppressed her growth hormone to 0.1. The cutoff for cure is 0.4. This is our early series, couple years into practice. 25 cases of acromegaly invading the cavernous sinus. I call your attention to these, and that is these incurable tumors. 2 of 3 NOS4 and 7 and 9 NOS3 tumors were cured biochemically. If they hit the new criteria for biochemical remission, we haven't had to date, this is 6 years into practice, any recurrences. So complications are really about the same for any tumors, CSF leak, sinonasal complaints that usually resolve by 3 months, mostly transient diabetes. We did have 1 case of permanent diabetes insipidus and panhypopituitarism, and that was in a woman who had several operations but was also on a experimental protocol of pasireotide down at OHSU. Most importantly, I think, for this series is 0 carotid injuries and no cranial neuropathies. So medical management, somatostatin receptor ligands, octreotide, lanreotide have become quite common. Dopamine agonist therapy doesn't really work well for acromegaly, but we do try it as an adjunct for those patients who aren't responding to the others. Growth hormone receptor antagonists are terrific. They're just stinking expensive, and insurances won't pay for these medications. So this is sort of like antihypertensive drugs. You have normal blood pressure until you stop taking your medication, and then your blood pressure rises again. Same thing here. And this could be as expensive as $5,000 to $15,000 a month in therapy. Radiotherapy we talked about. Again, this is never a first-line therapy, but what about the cases where we remove all of the tumor and radiographically there's nothing there, I don't see anything at the end of surgery, and they still have persistent oversecretory state? These are the patients we usually send for some sort of radiation. And you have to counsel them with regards to biochemical remission rates, which aren't good, 30 to 50%, but they're certainly going to be better than repeat surgery in that scenario, and cranial nerve injuries. The biggest risk of radiotherapy to the pericellular region is going to be panhypopituitarism. And I counsel patients that about 80% of them by 10 years are going to have multiple axes affected. And again, a lot of the patients that we follow in the clinic are people that have had radiation for other diagnoses. And it is something that has to be on the radar of their primary care physicians. So manifestations of hyperprolactinemia, women come in with very small tumors because they have a built-in laboratory with their monthly menstrual cycle. Men wait till the very last minute. They don't tell people that they're feeling crummy and have decreased libido. When you look at a prolactin level, the magic number is really 200. Anything less than 200, no matter what the size of the tumor is, could be due to stock effect. The vast majority of the time, anything greater than 200 is going to be diagnostic for a prolactin secreting tumor. We talked about the treatment. The folks that come to me are intolerant to the meds or resistant to the drugs. Despite increasing levels of the drug, the prolactin level continues to increase. And a very common goal of my female patients is obvious, to conceive. And I would say the vast majority of the patients that I wind up doing surgery are for microprolactinomas in women that don't want to take the drug during pregnancy, and then radiation therapy. So here we go back to our case, large tumor, distorting the optic apparatus, bitemporal field deficit in the cavernous sinus. In my hands, I can't cure this patient biochemically. There's something different between prolactinomas and those tumors that secrete growth hormone and ACTH. I'm way, way better at curing those folks, and these people always go on to medical management. And you can see, this is just 2 weeks later, we get an MRI scan to document shrinkage of the tumor. Now we can make out the optic chiasm, pituitary stalk, the pituitary gland sitting up here on the pericellular region, and the residual tumor here. And that's her. So that's our goal. On the medication, and she had a baby. Ophthalmoplegia, I told everybody in the room that apoplexy is going to be a clinical diagnosis. Never let the radiologist call you and say, hey, your MRI showed apoplexy. And the only way they can say that is if they've seen the patient. And we all know the radiologists don't see the patients. They sit in the radiology reading room. So severe headache, worst headache of the life, or in this scenario, ophthalmoplegia. So this poor guy couldn't look to his left or to his right. Yeah, that's not going to work. Okay, so this is a case of apoplexy in that gentleman I just showed you. A couple points to see. One is that the bone is eggshell thin, a sign that this tumor's been growing for a period of time and remodeling the bone. And if we saw the video, apoplexied tumors are almost like cottage cheese. They just come out necrotic and nasty looking. And this is almost a 20-minute operation, very, very quick, because the tumor wants to come out at you. Goals of therapy we talked about. When a craniotomy is needed, it's not the worst thing ever. We don't shave the hair. People can go home the next day as well after a craniotomy. We use a lot of different approaches surgically, and this all gets down to where the tumor is in relation to the critical structures. So transorbital approach and a transnasal approach are coming underneath the chiasm. So in the case of a pituitary adenoma where it's lifting the chiasm, in my opinion, it's better to come at it from the pathology side. If the tumor's on top of the optic chiasm, as in the case of a tuberculum cell meningioma or something like that, it may not be wise to go from below. It'd be nice to see the optic chiasm from above so that you don't hurt that. Here's a quick case, very, very young patient, severe acromegaly and gigantism, and a nasty tumor, very, very nasty tumor that required 3 operations, transfernodal operation and 2 craniotomies. So in her case, we got an angiogram with a cross compression study to show that she had good collaterals. Why? What if I get into the cavernous carotid artery? What if I can't repair that artery at the time of surgery? I want to know how my decision algorithm is going to go in that worst case scenario. In a case like this, you could almost sacrifice the cavernous carotid artery if you had to, which is almost unheard of here for adenomas. Again, I want to stress that point. The pathology of adenomas is very good to the artery and the cranial nerves. So after all of this, transfernodal surgery and 2 craniotomies, the patient had normal IGF-1 levels and a transient third nerve palsy. Cushing's disease, real briefly, we talked about the moon phases, the buffalo hump. It happens in young children as well and can be misdiagnosed. The workup is going to entail a 24-hour urine cortisol level, nighttime salivary cortisol levels, and in the event we're unable to make the diagnosis because the MRI shows no lesion, we usually move to an inferior petrosal sinus sampling study, and that's to localize the tumor to the sella and not to the periphery like the lung. Okay, my videos aren't working, but here's a case, pituitary gland, and you can see this tiny little grayish appearing thing here. This was a bud in the medial cavernous sinus, and we're able to take that out completely. Just 3 months after surgery, you could see the difference in the patient. They rapidly lose weight and begin feeling themselves, sleeping better, having more stamina, things like that. Remember, with Cushing's disease and acromegaly, for that matter, you're fighting against decreased life expectancy. While the pathology is going to be benign, the syndrome is absolutely malignant. And this is just an example of a 40-year-old, this patient doesn't look 40, who died on my surgical waiting list with right heart failure. Meningiomas, real quickly, and then we'll open it up to questions, I think. I ran a little late. All meningiomas are not created equal. If there's one thing I could tell everybody here, and I hate when people say, oh, meningiomas, you have a benign brain tumor. That's absolutely not the case. Our neuropathology colleagues here in the back will tell you about 15 to 20% of these tumors are higher grade. What does that mean? Well, the pathologist is going to make that diagnosis based on the review of slides. And they usually assign a World Health Organization grading scale of 1 to 3, with 1 being benign, and again, there's some bad actors in that group, and 3 being frankly anaplastic or malignant. Atypical tumors seem to fall in between there. And this absolutely relates to not only life expectancy, but recurrence rates over time, but overall life expectancy as well. And that you can absolutely relate back to the World Health Organization grading scheme. These tumors are going to present with progressive neurologic deficit. Headache is a little more common than a coin flip. Seizures, headache and nausea and vomiting, usually due to increased ICP. And really, the physical exam is going to dictate what sort of radiographs you're going to get. And our workup can include CT scan if you want to get a really good sense of the bony anatomy and which neuroforamina are involved. Specific MRI scans, again, a venogram, MR angiogram, and then again, angiography and potential for embolization. Here's a quick example of a case of a sphenoorbital meningioma, and what I was alluding to before, you could see the normal lateral orbit on the contralateral side, and this is a hyperostosed lateral orbit and sphenoid wing on the side of the tumor. You could see the soft fleshy tumor within the orbit itself and the obvious proptosis. This bone sometimes is just simply hyperostosis, and sometimes it's actually bone infiltrated by tumor. I always send it for pathology, and I'm not really good at predicting which of the two it is. And to treat the proptosis and the visual decline, a lot of times these patients will present with orbital pain and headache. We have to decompress the orbit completely and usually reconstruct that with more room back there to decompress. This is just an example of a post-op study. I think I'm going to open it to questions. I'm sorry that we didn't get a little further, but let me put a quick plug in for our... So every single tumor that we operate on here or at the University of Washington Medical Center gets banked. So what that means is before surgery, the patient's going to sign a consent usually so that we could harvest their tumor. Sometimes we start cell lines, primary cell lines with that tumor. We certainly keep it frozen in liquid nitrogen for subsequent genetic studies, proteomic studies, and we also harvest blood. And there are vast majority or a large number of projects that are ongoing. And really this gets back to our partners in other areas of oncology who have used these sorts of studies to dictate targeted and customized therapy. Everybody knows of the cases of CML, and GIST, melanoma, etc. And these are the sorts of data you can get. So this is a SNP array on multiple pituitary tumors. We could do sequencing targeting specific genes. Proteomic studies. This is in conjunction with Dr. Jing Zhang in the Department of Pathology as well. And really the goal is to take those bad actors, those aggressive skull-based tumors, those tumors we can't cure with our current armamentarium of weapons to cure, to find out what could in fact help us in targeting their disease states. And this is the larger pituitary team here at the University of Washington. Any questions? Yeah. Dr.
You may have mentioned this in the beginning, the ratio of the non-screening to secreting tumors. How many of these are just non-screening altogether and don't require any?
It's probably about 20 to 1.
Okay.
Yeah, with the majority of those 1 being prolactinomas.
Okay. And then the second question was just the pituitary affliction, which is something we sometimes see. You mentioned that with these surgeries really no injury to cranial nerves. If they come in with cranial nerve injury, how often do they get recovery after?
Everybody does. And in fact, again, in Europe, where they treat apoplexy a lot more conservatively, if folks come in with a fixed deficit, they're treated expectantly. They watch them clinically and replete them. I mean, usually those patients, just so everybody knows, they'll die if you don't give them cortisol replacement. So they need stress dose steroids right away. And in fact, if you look at their cranial nerve recovery rates at 6 months, they're identical. So the recovery is going to be a lot quicker with surgery, but that's a different scenario than somebody who's continuing to decline. So if I have a surgeon who comes in with apoplexy, which I have, and they need to get back to doing surgery in a couple of weeks, surgery is usually the way to go, even if it is a fixed deficit. Yes?
Can you comment on your approach to postoperative DI in a patient who did not come in with DI in the first few days, and then what happens to them?
Sure. And that's going to highly depend on the pathology. But if I take adenomas, for example, at least here, there's essentially a tumor capsule that protects you from the pituitary stalk in the gland. The art of this type of surgery is really identifying that capsule, because if you stay on your side of the capsule, you're never going to irreversibly hurt the hypothalamus, the pituitary stalk, and that sort of thing. If the surgeon is confident that that was never breached, it's almost always that the patient's going to go through that triple phase response. And if the patient can drink and they have a thirst mechanism, my preference is to just let them do that in front of us. And why do I say that? Because the only way we're going to hurt them is if we drop their sodium too far down, right? And so if you catch them on their trend toward SIADH and that triple phase response, and you give them DDAVP, that can be catastrophic. And I know that that's difficult for some of the ICU folks to watch that. Now, in the case of craniopharyngiomas, where 50% of the time, no matter what I do, they're going to wind up with permanent DI, that's a much different scenario, and I encourage the use of DDAVP. Yes?
One last question. You showed a lot of images, very large pituitary tumors. Do you ever do it in phases, either with embolization or radiation and then surgery, or do you do surgical first?
So I'll tell you, the hardest cases I've done just across the board are going to be those that have undergone radiation at some point prior. Why? Radiation destroys tissue, and it's going to induce scar between the tumor or residual tumor and those critical structures. And I think most skull-based surgeons would agree with that. So radiation as an initial modality, never. Medical management, sometimes. So I've had cases of prolactinomas that become medically resistant. And if that happens, if the prolactin level keeps going up, and despite our efforts, it's growing, then they can go to surgery at that point. Other questions? Okay. Oh, yep, sorry.
Well, I was just going to ask if you've seen any patients present with corneal lesions, either postoperatively or preoperatively, and whether you've seen patients with corneal lesions specifically recover their memory.
That's a really good question, too. I would say that from a transfenoidal operation, that's extremely rare. The cases I have seen that in are going to be those that are done transcranially and interhemispheric transcallosal. And I got to be honest, I've seen that in my own patients as well for a variety of other lesions. And when I think that I've been ginger and gentle and everything, I still wind up with a goofy patient. And I think it largely depends on the degree of manipulation of the fornices at the time of the surgery. Yeah. I'll extrapolate that, or I'll answer that also by saying I'm always surprised, for the cranial nerves we can monitor at the time of surgery, like the facial nerve, when I think I'm being the most ginger and gentle with the facial nerve, and it's angry. I mean, you'll hear the EMG going, brrr. I'm like, geez, I just looked at the nerve. So, I mean, it's got to be the same thing for the fornices, Yeah. Other questions? Okay, well, thank you so much.